Oh, there I am. Well, good morning. I'm Kai Holland, and I'm going to go ahead and kick off 1 Million Cups for this week. 1 Million Cups is a Kauffman Foundation program run around the country, generally on Wednesday mornings, with the idea that if we could have 1 million cups of coffee, what could we change in this world? And so this Anchorage chapter of the 1 Million Cups has been taking place for about 10 years now, and we're glad to have the support of Moja Co-working Space and David, as well as Alaska Coffee Roasters, has helped us out with coffee. And looking forward today, a presentation by Dr. Philip Mendoza, who's going to tell us a little bit about his practice and his work here in the Moja Co-working Space. And we can, I hope, from there kind of riff on the issue of innovation as it relates to the healthcare industry from there. 1 Million Cups is intended to be kind of a front door in our community to the startup ecosystem. It's a great place for people that are interested in entrepreneurship to come meet up with some other folks that are in that ecosystem, begin learning about how do I get started? Where are the resources? What are the right tools that might be helpful? Got a resource sheet there by the door if you want to take it on the way out that says basically how do I get started if I want to do that. But I want to encourage you both to consider presenting here in the future, as well as if you run into other entrepreneurs that are working on something creative and innovative. Folks don't need to be, quote, ready to come present here. This is more about somebody who's working on an idea, wants to figure out how to take their next step and to share where they're at, where they're trying to go, and to give the community an opportunity to support that entrepreneurship and that founder in their journey. So this morning we'll begin with Dr. Mendoza and his work with his practice, and I'd like to welcome you to 1 Million Cups. Thank you.
Thank you, Ken. Good morning, everyone. Thank you for having me. Yeah, learning more about 1 Million Cups and Umoja. I'm just excited about this chance to pick your brain, the collective wisdom in the room and this network. So a little bit about me. I'm a family physician by training. I finished my med school training in 2007, so I've been practicing for 16 years. And I've been practicing in a community health center setting. So it's a safety net clinic. Have you guys heard of community health centers? And so that's been the practice setting that I've been in primarily up until about 3 years ago. I wanted to do something a little bit more intimate where I could spend more time with patients. And I'm a bit frustrated with the American healthcare system, and just practicing in a bigger system. I just felt like I was pushed to see patients in 15 to 20 minutes, and closing health disparities is something that's near and dear to my heart as a Mexican American, first generation immigrant to the country. And so I needed more time to close healthcare gaps, to educate my patients, which I feel is a big part of my job. And I wasn't able to do it in the traditional setting. And I was just kind of burned out with just a bigger system. So I started my own private practice. I've never started a business before, so this is all new to me. And I'm about 2 years into building my private practice, and I've been seeing patients for about 1.5 years now. And finding Umoja and this co-working place has been a blessing because I was co-located with a cardiologist in town. Part of my business plan and strategy is to keep my overhead expenses as low as possible. And I'm a micro practice. I do the scheduling, start to finish. I do it. I answer the phones. I see the patient. I take their vital signs. I collect payment at the end. I coordinate their care. And all my visits are 1 hour in length. And if I need more time, then I'll do it. I'll take hour and a half, whatever it takes. I do home visits. I do a lot of telehealth. I do evenings and weekends. Essentially, I want to be able to meet patients where they are and meet their needs, targeting working families and Spanish speakers. With my background and skill set, I really want to focus on that patient population because I feel like that's where I could be of the most help. And so, yeah, I really enjoy the flexibility that I have now in my scheduling. And if a patient needs a home visit, I wasn't able to do that at my other practice. And so I could go and see, an 84-year-old gentleman with Parkinson's disease and status stroke. And it's really difficult for him to leave his home. And I can go and visit with him. So that's a little bit about me, my background, kind of my vision and mission. but I do find myself, you know, with a lot of questions around just as a business person now. I've been trying to managing all the ins and outs of my practice. Questions come up about, you know, what if somebody wants to volunteer at my practice? Well, what are the medical legal pieces that I have to have in place to maintain privacy and, um, you know, expenses, doing our taxes this year. So, what can I count towards business expenses and what can I not? Depreciation schedules and there's just a lot that I don't know. And so being part of a networking community like this where I could pose those questions or reach out to somebody who is maybe more knowledgeable in that area. I was a physician executive for the past before I transitioned into this role. And so I'm pretty familiar with as far as the medical industry and the medical legal aspects and managing patients, but in the business realm, I still have a lot to learn and grow. So that's a little bit about me and my practice. Is there anything else that I could share that would be helpful to this group?
There's, just before we get into broad questions, I just wondered if you kind of summarize, kind of what the challenges are and what you've kind of learned about starting a medical business.
Yeah, what I've learned is that it's challenging in the American healthcare system to be a variant. And so I think my micro practice is a variant. So I'm trying to do something that is against the grain of the traditional medical system. I accept insurance. And so I'm kind of dancing in two worlds, right? Because I want to spend time with my patients. I have a biller now that's going to help me with my billing since I do take private insurance, Medicare and Medicaid. So to keep my doors open to Medicare and Medicaid patients, they're not the best payers, and play within the big system, but doing something that's different, that's micro, or trying to keep my overhead low, but still have enough revenue where I can sustain myself. I have 2 other part-time jobs right now to sustain myself financially. I just use my savings and I didn't take out any loans to start up my business. So I still have other jobs to pay bills and college tuition. I have 2 children in college, and I'm trying to start up my practice. I'd like to be able to have a sustainable micro practice, but it has been challenging to have something that is non-traditional in a bigger ecosystem of an American healthcare system that's dysfunctional and expensive. But I feel like really at this point in my career, it's really the only way for me to continue to practice in the United States. I've practiced in different countries, but it's if I continue to if this fails or if I decide not to do this anymore, my private practice, I don't know how much longer I will actually practice medicine in the United States because it is just, I don't feel valued as a family physician. And I feel like the American healthcare system just creates so many administrative burdens on me as my team. And I can't really do what I want to do to close health disparities and take it for any patient. So it takes health equity, right? It's equal resource. It doesn't cut it when you're talking about closing gaps in healthcare. There's language barriers, there's transportation barriers, and financial barriers. And it's part of my passion to be the change that I want to see and close those gaps, which takes more time, it takes more energy, it takes more resource. But the American healthcare system makes it very challenging, sure, for someone to do that and still be financially sustainable. So this is my attempt to still practice medicine in the United States. And my heart be happy doing what I love to do and addressing health disparities. That's really what my professional career, I'm dedicating my professional career to. So that's a little bit about me, my background, and kind of that dancing in those 2 different roles has been challenging for me.
Cool. Well, thank you for coming and presenting.
Yes.
Let's open it up for questions and just a discussion and whatever happened to my screen on there, whatever, I'll deal with that. But a small group, please, as we start off with some discussion, the question, introduce yourself and in terms of who you are, and some background for Dr. Mendoza to know who's there, and so the rest of us know who's here too. But I'll go fix that. Go ahead.
Yeah, hey, I'm Graham Benoyer. I'm owner of several different businesses here in Alaska. I'm a veteran, and I love listening to people's concepts and ideas and find out how I can connect it to other things that I know about going on. So I fancy myself sort of a super connector. But what are like the telehealth requirements? Have you done a telehealth? And what are the telehealth requirements that like kind of keep you in a box of doing what you want to do?
Uh, post-COVID, like, pandemic, telehealth rules, they relaxed them, and they used to be just behavioral health providers that could bill for the service. And they were very particular about which entities, where the provider was and where the patient was. And so CMS, Medicare, they kind of relaxed those rules during the pandemic that are still in place. Up until what I understand is the end of 2024. And then they're gonna return, the plan right now that CMS just put out is they're gonna return to pre-pandemic rules where only behavioral health clinicians can charge for a telehealth service. And there's, of course, a lot of pushback from the community, from patients, because, it's been a great way to overcome access issues and transportation. So right now, I'm able to, there's modifiers and I can still bill for my telehealth services. It doesn't matter where I am, as long as I'm physically in the USA. But what really matters is where the patient is. I have to have a medical license where the patient is physically located, and then document that in my chart. Okay, the patient was here, that was here. And as of right now, I'm getting reimbursed as if it was a face-to-face visit. But it seems like once CMS puts out their regs, everybody else follows suit, all the other payers follow suit. And so one thing that's concerning me is, will I be able to sustain my practice beyond 2024 with the change in the statutes? Like, if the insurance companies don't want to pay for it, can I still charge? Because they're very particular about charging for things that pay and billing the patient directly for a service that the insurance doesn't cover. Medicare, Medicaid are very rigid as far as documented. You cannot send a bill directly to the patient if they're a Medicare or Medicaid beneficiary. There's very stringent rules around that. And so if I cannot offer telehealth to a Medicaid, a lot of my patients are Medicaid and they get reimbursed for that, that's really going to affect my practice model. And then it's probably going to be a question of, well, do I want to take insurance at all and just go to self-pay, cash pay? And that's a challenge for me because I serve, a vulnerable patient population that is not resource rich. And so, that's kind of where I find myself. In the short term, it's okay. I can still bill for the service. In the long term, it's like, does my business model need to change to still be sustainable? And maybe if I still want to offer the same services and most of the payers aren't going to cover them, then just switching to a more cash-based type practice, like a concierge practice.
Thank you.
Yeah.
Any questions? Yeah.
Melanie Lucas Conwell. I run the 49 State Angel Fund. We invest in early stage scalable startups in Alaska. And I'm curious, as you've worked in or practiced in different countries, what has worked well in other places? I know that the American system is very broken when it comes to healthcare. I'm curious what you've seen out there and what maybe there's some hope that America will change their practices.
Yeah, there's been a lot of studies kind of showing what are high performing systems doing that we could model and incorporate. And so they remove barriers of paying for services, so the financial barriers to accessing care. So getting people insured, having more universal coverage for everybody, all their citizens, and then for people that live in remote areas or impoverished areas, making sure that transportation barriers are addressed. They invest in primary care, so the gap between private specialty providers and family doctors or pediatricians, OBGYNs, the primary care, the gap in compensation is very narrow, and here it's pretty broad. And so it disincentivizes medical students to go into primary care because of the debt that they carry. They also invest in working families. So as far as childcare, training, education, they invest in those things to make it easier for working adults to participate in the workforce without carrying a burden. So those are some of and Cuba actually has very similar health outcomes to the United States, and they spend about 15% of their GDP. So it is a fair chunk of their GDP. We spend closer to 19% of our GDP, but we spend a lot more money in our health outcomes are much better and we're comparable to Cuba. So our hunger rates are actually higher than Cuba's. Our so they also Cuba was interesting asking community health aides. Have you guys heard of community health workers? And so that is such a valuable resource. So in Cuba, they assign a team, a family doctor, a community health worker, and like a nurse, a trio of three to a neighborhood, a geographic area of 600 to 700 people. And that community, that area, they house the physicians, they arrange the housing. And so the provider is there to serve that patient population, but they're integrated into the community. And then the community health worker is linking the patients to the medical provider. They just go around and, what screenings are you due for? Is anybody sick in the home? And then if they are ill, they can come back to the primary care doctor. I think that's something that we could leverage in our country. And because of my background and my passion for addressing health disparities, I think a lot about structural violence and how we can address racism in medicine, racism in our country that is hurting people of color, and has created, like in my perspective, I think a lot of wealth gaps between people of color and others. And so, in thinking about that and through that lens, should this geography concept, as opposed to addressing health disparities by race or ethnicity, addressing health disparities by geography, by zip code, I think is also a very novel concept and can break down barriers. Because when I hear racism, medicine, or those topics come up, they're very passionate conversations and people can get amygdala hijacked. And there can be emotions of anger, frustration from both sides, right? And that kind of prompts the conversation a lot of times falls short, I think, in trying to get to a solution. And so my thinking and some ideas that I'm trying to put out there in conversations around health equity is this zip code idea that Cuba has been successful in, and trying to address the needs of a patient population by geographic area and those needs, because rural and urban are different and different pockets of the community have different needs. And then maybe that could lend to healthier conversations about health inequity, and not including race and ethnicity. That has the origins of race and ethnicity are, they are divisive in nature, and they originate in a place to, where there was a Black person was worth 2/3, like 1/3, so that's the origins of this category of race and ethnicity in our country, is an oppressive nature. That's where those categories come from. So my perspective and my belief is that in and of itself, using race and ethnicity to address health disparities is in a way part of structural violence, because you're perpetuating that line of thinking of race and ethnicity that was constructed by white men to oppress people of color. So I'm trying to frame up my discussions about health equity around geography, what a certain patient population's needs. And that's what I'm trying to do here in Anchorage. And located here in this part of town was also very intentional on being able to find a home on my medical clinic here in this part of town, is where I to overcome transportation barriers and so it's not a vacant island of accessing medicine or food, I think food deserts or health deserts, to try and bring more resource to this part of town. So I don't know if that answers your question. I shared a lot about my own personal belief in my value system, but I hope I wasn't offending anybody.
Other questions?
As far as like telemedicine, telehealth, what are the differences in restrictions through COVID and then after 2024?
During COVID, there was a lot of leniency as far as what we could use. So we could use FaceTime, we could use Zoom, and there weren't a lot of more rigid regulations about privacy and security. But now those things are starting to come into place as to, okay, if you're going to use a platform for a live telehealth, it has to meet certain security requirements in it for privacy rules. And so my platform is through my electronic health record system, so it meets the more stringent requirements that once the official declaration of the pandemic goes away, and you can't use FaceTime and these other, like just a general Zoom account, you have to use a platform that has additional privacy features. So that's going to change once I think the declaration has now officially ended, so all the rules are tightening up. And
Okay,
CMS and all the insurance companies are just, they follow CMS and trying to tighten up the rules. And things are gonna really change, I think, next calendar year. They're kind of letting things float for the rest of this calendar year. Even though the official declaration ended, they're gonna let things kind of continue until the end of this calendar year. But then change more rigidly in 2024.
okay. What are the federally defined characteristics that differentiate telemedicine and telehealth? Are there a difference between those two?
I think there is a few, because like if you say it's it's challenging because the phone, right? So if you don't
Yeah.
use video, so that distinction where is phone included, a phone only audio consult included in telehealth, or is it just when you say telehealth, is it audio and real-time audio
Yeah.
and video?
I'm trying to wrap my head around this, that change, does telehealth as a whole change in 2024? Or does telehealth and telemedicine requirement? I'm trying to quickly educate myself on this on the alaska.gov website. And so I'm reading things that are.
Yeah, I need to learn more about that. Like my biller and coder, she knows like what bill you can submit to the insurance and
Yeah.
will get reimbursed and how it has to be coded and there's certain like codes, like modifiers that you have to put on the bill in
Uh-huh.
order for them. And I practice in Colorado and in Alaska. I have two divisions of my practice, and so Colorado has different modifiers that you have to have. So there's all these nuances of how you submit the bill.
Yeah.
And if it's use one code for audio only, and then another one if it's audio and video,
Yeah.
and then the modifier on it. So the billing gets really tricky so that the insurance company will recognize it and then reimburse. And then I think the plan right now for CMS for Medicare is to exclude a lot of these for medical services, which is going to be a big challenge in Alaska. Knowing our geography and the challenges that people face to access medical care and our winter conditions. A lot of my patients struggle in the winter to get around because they walk.
Yeah.
And public transportation has its good and bad, and a lot of my patients have a difficult time accessing public transportation. So telehealth has been a great tool to be able to reach those patients in the pinch, and with COVID to minimize the communicable disease exposure. So there's not somebody sitting here that's actively sick and coughing and then exposing everybody else in the building. Telehealth is a great way to kind of quickly protect the patient, protect staff from also getting exposed.
In the military, it's done wonders because people didn't have if you go to seek treatment in the military, you have to go at 6:30 in the morning, you're there until you get seen sometimes at 1, 2 o'clock in the afternoon. Once you set to sit, but with telehealth, they've been able to work through some of that stuff. Shorten the amount of time that people are at the office waiting. And then that is also subsequently encourage people to actually seek treatment. Because I'm definitely one of those where I hate the doctor's office. I don't want to go. I'll just deal with it and hopefully it goes away. And then and now I've got nerve damage. So that worked well.
Yeah. Patient really like that. An older woman that she came out with COVID symptoms, and she was here in Alaska. I was in Colorado, but we were able to connect via telehealth. And I know her past medical history, and I know the drug interactions, and so it's just a lot easier for me to, I think, safely care for her through telehealth when we're in different places as opposed to going to urgent care.
Yeah.
And they might not know all the medicines that she on and all her comorbidities and Paxlovid. That's the tough thing about the Paxlovid. It has a lot of drug interactions, and if the kidneys aren't working, you can make them sick from too much Paxlovid. So it's been great for COVID to treat COVID using telehealth.
My name is Yubal Naidu. I'm a product manager at Meta. I've been a product manager in Alaska for almost 5 years now and was involved kind of in the entrepreneurship space prior to that. My question is it seems like you're dealing with a lot of really complex problems that you have to solve, and probably a couple of headwinds that a number of people in your industry are dealing with: burnout, not serving the communities that they really want to serve because for whatever reason those communities are disenfranchised, and dealing with maybe new headwinds that will start blocking off telemedicine access and revenue coming from telemedicine and telehealth. I wanted to ask you, and I know that this is a fuzzy question and maybe sort of a leading question. What does success look like in this for you? Is it finding ways for you as an individual to deliver care the way that you want to deliver care? Or would success also potentially be finding ways to solve these problems and then opening it up to bring in new practices and providers in, maybe as a nonprofit or using different structures to start delivering healthcare throughout the nation or various communities in a better, more inclusive model?
That's a big question.
You know, but I think about your question a lot, like essentially, what do I want to do with this work, you know?
Mhm.
And I think initially, my thinking was meet the needs of the community, and then be able to follow my heart. So address health disparities and spend time with patients and minimize the noise around me as much as possible with my experience in the healthcare industry, trying to leverage that knowledge so that I could deal with the noise, so I could focus on patient care in the way that I wanted to, and health disparities and kind of in a micro practice way. Being in my previous work, I was the chief medical officer for my healthcare, my organization. So we touched 30,000 lives, 50,000 lives. And so talking about like systems of care, right? And kind of scaling up things that are working well. If this works well, and it can be a model for other practices, I think that would just be like a bonus. But I haven't really shared my story or like along the way to see if other physicians are interested. There are micro practices around the country that are trying to do the same thing, or direct primary care, but they would charge like you probably heard of these, like a membership rate. You can access the physician, like you just pay a monthly fee per person or per family member, and it doesn't matter how many visits you need. You can, and it's always the same doctor and that team. And so I think maybe my model is a variant of that, but I'm billing insurance as opposed to having a direct contract with patients and families. And I did that because my patients are marginalized, and I didn't think they were going to have funds to pay me. Usually those are more affluent communities that could play a monthly reimbursement model or a monthly membership model. So I think my primary goal is to be able to spend time with patients and practice in a way that fills my heart, and that can prevent burnout so I can keep practicing in the United States, and minimize the noise around me by having the leanest, meanest team to help me deal with the challenges. And if it serves as a model for other physicians, you know, to practice, I think that would be a bonus. But it's so unique and kind of quirky that if it ends up being something scalable, that'd be awesome. Or lessons learned for something else, I think that would be a bonus. But I feel like I'm kind of fumbling and finding my way. So that's.
There might be a lot of other practitioners that are kind of in the same boat where they feel the same way, and they're maybe looking like, how can I do the work that I want to do, that I got into this for, but I can't.
Yeah.
And so there might be, and it might not be a revenue generating activity, but that might be an area where, you know, you could get support and like-minded individuals that solve like discrete portions of the problem that you're working on, and then you guys can all kind of deliver medicine to these underserved groups. Maybe not as a unit, but as a loosely committed team.
Yeah.
But
Yeah.
if
It's just the primary care, so it's a service type relationship. And other states have done it, and so in a positive way for both the families that want to contract directly with their primary care provider and pay for that service, they can go about it that way, or if they want to have it, essentially they have the insurance companies or the traditional system is still thriving and functioning in Indiana, in Colorado, and there's additional option for patients to contract directly with medical providers. So it's in states, because I practice in Colorado and I have friends in other states where it is allowed to have a direct contractual relationship for services between patients and primary care providers. It's been additive. It's like, oh, an additional option to meet the needs of the community, and hasn't really taken away. So I hope that Alaska can follow suit and just offer it as an additional mechanism to offer primary care for patients that, that's preferable to them. And also for the medical providers that if that's how they want to practice, they would give them an initial way to do so.
The questions about, unfortunately, the power outage, just I invited our online folks to have a chance to chime in. The power went out and it killed the wireless internet connection. So I just finally got myself tethered up to my phone to get a connection. But in the meantime, the folks were online, I think, decided that maybe we were done or something. So I feel bad for the folks who are online. I just invited there. But any other questions that folks have?
My quick Google search and back of the envelope math would said $7,000 is the average cost of health insurance for an individual in the US. Is that about right? Somewhere?
Sounds right.
Yeah, I just was doing it for a church pastor. Yeah, that's right.
Yeah, there. And then if you could say you serve 40 patients a month, that comes out to $280,000 a year. If you could contract like directly with on like a subscription model, right? For most treatment, like everything is in this agreement. Yeah, and you just pay whatever monthly fee, just like you pay your cell phone bill or your health insurance right now. You just pay that and you can see me as often as I have appointments open for you or whatever, right? Something like that, similar.
Well, the ones I've seen have been $150 a month.
Yeah.
I mean, it's a radical change when somebody right now individually is paying basically, $600-700 a month.
Right.
And if they could get for just the basic, I've got a cold, I've got the flu, maybe I've got COVID, my ankle's kind of bothering me, paying $100-150 a month to get basically unlimited access to somebody to help out. And then there's just a whole bunch of other ripple things that happen, because if you start going that model and then start going and paying cash for some of your other medical services, you find out there's a lot of savings in terms of you can get a lot of things at the hospital. They basically knock down by 50%. If you just walk in and say, I need help with this, I'm paying cash. And all of a sudden, and that's how the religious communities have really pioneered this thing. If you're familiar with some of the Christian ministries, they basically create their own insurance networks and they're self-insured. Basically, these Christian groups all get together and the model is we're all going to go out and we're going to find the healthcare we want. We're going to pay cash for it, get the cash discounts on it, and then we will collectively raise the money to pay the bills that need to get paid. That's about 1/3 of the cost of traditional insurance because there's no big overhead. Nobody's trying to make profit on it. And if one month there happens to be somebody that went in and had $1 million surgery kind of thing going on, there'll be a call that goes out to the community that says, our community had somebody that had a really major medical thing. We need everyone to cough up an extra $15 this month.
And right now, those two states you mentioned, Indiana and Colorado, that's
direct primary care is allowed. The models, direct primary care is the current term that's coined for it. And a lot of patients still carry catastrophic coverage. And so, if I get in an accident or I need surgery, or I have to be in the hospital for an extended time, but the cost for those kinds of plans they're not very expensive. And so it covers you so you won't go bankrupt in case something like that happens to somebody in the family. But then you pay cash or direct to the primary care provider, and your overall yearly expenses on healthcare will not be a lot lower. So, these pressures on the traditional American healthcare system I see it as a good thing because we're paying as a collective, we're paying so much money for healthcare, 18 to 19% of our GDP. And our health outcomes stink. Every time there's a GoFundMe, every time there's a bankruptcy, healthcare bank related bankruptcy is the main reason for bankruptcy in the United States. And so there's just one good thing is that we know the best practices. The hard part is the will in changing the industry because it's entrenched. There's so much money that's being made, and there's this component of structural violence of the have not and marginalized communities. And there's some benefits for the bigger system to continue to have marginalized populations. So there was the question we were talking earlier about best practices. The Commonwealth Fund is they're a great resource for best practices, and they put out a report. It's called Mirror Mirror. So if you do a quick search, Mirror Mirror 2021 from the Commonwealth Fund, and so they compared high-performing countries, affluent countries, Sweden, Germany, USA, Canada, and okay, how do they rank across for performance indicators? And we were the only indicator that we performed well on is kind of process, and that's really it. But everything else, as far as life expectancy, quality outcomes, burden on the care team. So there's so much waste in the system because we have to do so much paperwork and deal with different insurances, and each insurance has its different requirements, and so there's a lot of administrative waste in our system, and it kind of lays it out well. Okay, what are these high-performing countries doing that serves their patient population well, and they're healthier for it, and they spend less money. And so Mirror Mirror 2021 from the Commonwealth Fund, and there's best practices that they put forth. It's a great resource, I think, for what we could do to be a better performing healthcare system.
On the medical concierge conversation too, California allows it, and I used to work for Google and on benefits to have a concierge, and they would pay the monthly fee for employees and then regular insurance on top of that, of course.
Yeah.
And Google also had in-house physicians. I think Meta does too, if you're on main campus, but yeah, it definitely works and is a great employee perk if you know that your employer is going to pay those monthly fees for you to see a primary care whenever you need it.
Am I correct that when I've seen that with the companies I've worked for, that's actually been the insurance company that was providing a concierge service? And so it was kind of this inner little working because the insurance company realized that it was in their best interest to make available these same things that we can't have out in the general public, because it's a way for them to control their costs. Because if they can have these concierge services, the telehealth kind of stuff, like ASD, you have teledoc available, but it's the insurance company that has set up that benefit because they want to reduce the number of times that you have to go to a doctor's office and the number of times you get more severely sick if you didn't go to the office. So it's the insurance company that's still kind of, tweaking this system, I think. And I don't know Google for sure, but that's.
Because we had multiple insurance carriers.
Gotcha. Yeah, okay.
So we could choose that it was a.
Yeah, provided directly.
Yeah.
Mike. Cool. Well, we kept you on the spot for longer than I promised we normally do. What can this community do to be helping you succeed in your passion and your mission to create a sustainable practice and help grow this in a way that succeeds for you? What can we be doing to help you?
Just being part of this community, I think it just puts wind in my sails, because sometimes I feel I'm just in a little island, right, and kind of trucking along, fighting against the grain a little bit. So just being able to see the threads in conversation, or I don't know if there's like to pose a question, and if there's collective wisdom, kind of, especially in the business arena, and also like search engine optimization. Like I need to do that, but I don't know. It's there have been different companies that have reached out to me with hefty price tags. Oh, we can help you with your website. Then we can make sure that your SEO is all worked out and people will be able to find you, which would be a good thing for my company. But the sticker shock on that is, like $8,000 or $9,000. So if there's other resources that, other things that I could do that maybe are not as expensive that I could do that would help my my mini clinic, my micro practice perform better and let people know in the community that I'm available to serve them. I just became in network with Aetna. That was intentional because the public school system has Aetna, so there's a lot of work, like working families with children, and I thought my evening hours and telehealth and weekends could help families out.
Mhm.
And Blue Cross Blue Shield, so letting those families and patients know, oh, I can serve you, I can take care of you, I'm in network now. So again, those are my challenges right now, is just let people know that I'm available
Mhm.
for their families to care for them, and then just trying to be leaner, meaner, more efficient, and then this whole realm of like putting my face out there and letting it be known on the current platforms that young people use.
Mhm.
To yeah, just
Cool, okay, good. Well, if you stick around, if any of you are doing search engine optimization and have some experience with that, definitely take a moment, see if you can, help the doctor with any of that advice. The other thing is, one of our primary platforms for those kind of questions and resources is the Alaska Startups Facebook group. And that's basically where people go to post questions and try and crowdsource ideas on service providers and options and what people are doing for solutions. And you'll find a lot of folks on there that are pretty active in being able to help provide answers and resources to that. But I'm sure there's some great expertise here in the room also that could help you with that, and also be great for you to connect up with Melanie and talk a little about Health Tie organization. The next Health Tie Open Innovation meeting is next Thursday at 1 o'clock.
Yes.
And
Second and fourth Thursday.
yeah, and next week is something information, something fire. I'm missing the first part, missing the first part of their name. They every second and fourth Thursdays of the month is the healthcare open innovation sessions. They're really tight, nicely done 1 hour sessions. Was it
30 minutes.
Excuse me, I meant to say 30 minutes. My brain made, yeah, they just go from 1 to 1:30. And they're nicely done presentations on people who are doing innovative things in the healthcare field, and a little bit of time for Q&A. They're also recorded. If you go to the healthtie.org website, you can find the recordings to learn more about past presentations. But it's one of our 4 main innovation ecosystems in Alaska that's going on. We've got the Launch Alaska Health Tie, or excuse me, energy one. You've got Spruce Root doing the rural area, and this one doing healthcare. And then the ocean cluster one, a lot of you were mixed up with, that now it's gone to FDF, that's doing blue economy type innovation. And we're trying to build the military innovation ecosystem also. So cool. Well, thank you for taking the time to jump on my camp and be a part of the discussion. What other community announcements are there for startup land?
The Alaska Angel Conference is having their final event on May 11th at the Lusac Library, and that's a free event that's open to everyone. It's that evening, 5 to 6:37 p.m. And we'll have 4 startups that pitch, and we've been going through a 12-week process with angel investors in Alaska to gather $100,000 investment fund. And one of those 4 companies will be selected for that check that evening. And the 4 companies are Elevated Oaks Granola, Get By, formerly incarcerated, Staffing and Gig Work Connection, Prisma Text, Language Learning, eBooks, and Evergreen Compliance, oil and gas pipeline and compliance software.
So, and that was going to be in Juneau, it's now in Anchorage. So if you thought it was off your radar and you didn't need to worry about it, it is here in Anchorage. That's big change, great opportunity to come see some good companies. Seen most of these pitch before. They're really good. See what's going on, because all of them have been at it for a while. They're getting good at what they're doing. Yeah, there's some stuff that said May 10th before.
It's now May 11th.
Martina just fixed that. That was on the schedule yesterday. So then I've got it on nothing else. Cool. Also tonight is the Alaska Investor Network. Doors open at 6:45 and the meeting starts at 7:10, somewhere in there. They've got 3 companies pitching tonight. I'm not going to be able to.
Start tutors.
There we go. Yeah.
It was wild.
Yeah. So Anyway, it's in the Startup Digest that went out yesterday. It's got the list of them in there. They're pitching, and these meetings are open to folks in the community. If you're a founder, non-accredited investor, kind of interested in the startup ecosystem, the meetings are open. They've now created a kind of a dual track within the investment community, one for non-accredited folks to participate, the accredited one. Generally, what will happen is late in the meeting, once they've done the pitches, they may kick the non-accredited folks out in order to have a discussion about the pitches. They're still trying to work out their process on that one. It kind of comes and goes, but that's, I think the intent tonight is it'll be open from 7 to 9, and then they may go into an SEC accredited investor only discussion about the pitches and whatnot. There's figure that out. And then the other thing, Saturday is the finals for the Arctic Innovation Competition. That's noon to 5. I think it's going to be streamed online at 1 o'clock is when they're doing the final presentations. It's kind of a little hard to see. I know that the main event's up at Westwood and Fairbanks. And they kind of say that it's got some virtual stuff on there. I couldn't quite find the link on it. So, but anyway, if you're interested in Arctic Innovation Competition, Get By is also pitching on that one Saturday. And it's been one of our major stepping stones for startups in Alaska, has been getting involved in the Arctic Innovation Competition early on, along with some of these other activities we're mentioning. Any other startup-y kind of events or activities going on?
Next week, there's gonna be a financial class. We're putting the poster together, so I believe it's on the 26th to the 27th.
Okay.
I can confirm that. And then, so there's gonna be one financial class, and there's gonna be another how to start your business class. That's gonna happen on the next Thursday. But we're putting the final pieces on that, and that'll happen here.
Okay.
Those will be on the website. That information will be on the website.
It'll be on their social media. Yeah.
What kind of financial class?
Just talking about budgeting, talking about how to save money and stuff like that. Just basic for people that really don't understand it. So. And then the how to start a business, from the groundwork up. Somebody that's never started a business and stuff. So, business 101 kind of thing.
Well, you were making me think there's another financial thing going on. I think May 5th. Is that the one you've got going on, Melanie, or you mentioned to me?
Facilitating at an executive level class for businesses that are free course for businesses that have been in business for 3 years or more and have, I think it's $250,000 in annual revenue or more. And in my mind, their marketing looked like it was some form of executive MBA. I think it's over a few months. So pretty short, mix of in-person in Anchorage and virtual is the information I retained from what they sent me.
This stuff's all in. Okay, yeah, good, thanks.
Then this will
Yeah,
talking ahead and stuff like that. May 3rd, we're gonna have the 1 Million Cups brunch. So it'll be, instead of just an hour, it'll be an hour and a half. And it'll be, I will also be presenting for our organization to kind of get that out there. And then just kind of talking and putting ideas together for what to come for 1 Million Cups. And so everybody's welcome to that. And that's at 10 o'clock on May 3rd.
Can you say more about the brunch part? What's the insight?
Yeah, well, we just thought that, starting summer's coming around and stuff like that. And we just kind of wanted to see, where do we want to go with 1 Million Cups here? And then also just opportunity for myself to give a presentation for our organization as we start going out into the community. And so
our plan at the moment, if we can get, enough engagement, is to continue going for the summer. But pop up around town in the summer, in the parks.
Yeah.
And other community events, kind of move around a little bit, take advantage of it. It's gonna be nice and warm and we ought to be outside. So that's part of what we're trying to gear up for, and hoping to get support from folks that are working on businesses, and kind of the ethos that startups can't take the summer off. So, maybe we, figure out a way to keep this thing going ourselves. So anyway, Startup Digest has got all this information in it. If you're trying to figure out that, it comes out weekly in the email, the link and everything for it's on the flyer, and it's there by the door if you're not already signed up for that. So any other final announcements?
Well, for Pacific Community of Alaska, we have a health and resources fair on June 23rd, and it's open to all. So we're getting vendors to get like free screenings, free vaccinations and immunizations for the kids and physicals. So feel free to come by. It's June 23rd. It's gonna be at Esplanade Center, and it's open and free to all to the public. And tomorrow we are having a step into wellness. If you need a exercise or a little bit, get some stepping going, it is free to all. Join us as Bernard again to do some stepping with us. And because tomorrow is April 20th, wear your green, red, and yellow if you want, so everyone can walk with the reggae music over there.
The FAST program applications close at the end of the month. The FAST program is a non-dilutive federal funding program for like business serving or government serving programs. I believe that they got grants about almost $125,000 during one way to do stuff in that space.
I think it's for more tech-based businesses.
Cool. Going once, going twice? All right, sounds good. So those of you that at the military, I think I mentioned this to Graham, I've got the notes. I'm gonna try and get them out today from last week's meetings. We had a military meeting on that, so I'm trying to finish that up, but it's a great meeting, and appreciate it. Thanks for that. Yeah, today's the Tech Expo that's going on in J-Bear right now. It started at 9 today. It's going on today and tomorrow. It's something people had to apply a couple weeks ago to kind of get in, because you had to get access to the base, and deal with some base access to their having an expo, and they invited companies that have potentially some sort of opportunity to work with the military to be able to be on base to show what's going on. So I got launch company, I think I got them signed up, and Triveris that already does stuff for the Navy on there, and Beaded Stream, and we've got some of our startups that tried hooking up with that, as well as kind of the traditional businesses that do other support services for the military. So that's going on today and tomorrow. Hopefully we'll find out maybe next week more about how that went, what happened, but cool. All right, well, thank you again, Doctor, for thanks, Andy. Okay, and see you, and you're welcome to hang on and take advantage of space. David, thank you for the space and Motion provides, and there's still more coffee and plans to hang around here. They've been very generous in letting us come and use this space, but also hanging out for a little bit so you don't have to run off. So I know I usually go find one of the hot desks over there and usually work for a few more hours here and take advantage of being here, and a good place to work. So appreciate that, and I encourage the rest of you to hang out and enjoy the space and the company. Cool. All right, I don't know what happened here with this power outage. I don't know what I've got for recordings and pieces of recordings.